A 75-year-old gentleman who is a known patient with COPD presented to the emergency department with dyspnea and shortness of breath. 3 days ago, he was started on prednisolone by his GP. After arrival to department, he has been given back-to-back nebulized salbutamol and ipratropium bromide. The oxygen concentration has been titrated to 28% to achieve a saturation of 88 to 92%. Due to his poor response to treatment, an aminophylline infusion is started. After 30 minutes, ABG is performed and it's given below. pH 7.3, PCO2 7.6 and PO2 8.1. And we are asked about what is the most appropriate next step in management of this patient. Option A, intravenous hydrocortisone. Option B, increase his oxygen to 35%. Option C, non-invasive ventilation. Option D, decrease his oxygen to 24%. And option E is intravenous magnesium sulfate. So what do you think, which one is the answer? To answer this one and to go through a short summary about acute exacerbation of COPD, continue watching the video. Ladies and gentlemen, today we'll talk about acute exacerbation of COPD. In acute exacerbation of COPD, here we'll basically talk about the management options available. So, firstly, the most common bacteria that cause infective exacerbation of COPD are Streptococcus pneumonia, Moraxella catarrhalis, and Haemophilus influenza, which is the most common pathogen. And don't forget that respiratory viruses accounts for about 30% of all the cases with acute exacerbations. Having said that, according to NICE guidelines, first you can try with increasing frequency of bronchodilators such as nebulization with salbutamol 5 mg and ipratropium bromide 5 mg. And also, you may give oral prednisolone 30 mg daily for 5 days. And keep in mind that NICE only recommend antibiotics only if sputum is purulent or there are clinical signs of pneumonia. Otherwise, don't prescribe antibiotics to your patient. Okay, and then you can move to controlled oxygen therapy via Venturi mask. With your Venturi mask, you can start initially with FiO2 between 24 to 28%. And then keep in mind to maintain saturations between 88 to 92%. And this is a very important factor because not too little or not too much oxygen should be given. Because if too little oxygen is given, patient can have anaerobic metabolism and respiratory acidosis. So these are some of Venturi mask. I hope you already know them. And according to each Venturi mask, there is a percentage of oxygen delivered, and that's it. The next step is management is IV aminophylline. You should give aminophylline if there is inadequate response to nebulized bronchodilators. If all these medical options failed or patient is not responding to any of them, then you may try with non-invasive ventilation. Non-invasive ventilation is delivering oxygen via face mask or overhead mask or any mechanism, BiPAP, that is not invasive. So, you may start non-invasive ventilation if maximal medical treatment is not effective. And if ABG shows respiratory acidosis, then you should decide, yes, I'm going to give this patient non-invasive ventilation. And while doing this non-invasive ventilation part, there should be a clear plan covering what to do in the event of deterioration and ceilings of therapy. That's a must. Finally, if all these things failed, you can proceed with invasive ventilation, which is intubation or any other option. So, as I said, if non-invasive ventilation fails or is contraindicated, such as in cases like respiratory arrest, high aspiration risk, or if the patient is having impaired mental status, you can proceed with invasive ventilation. So, we'll see some case scenarios and what is appropriate management option. If patient is having low pH and hypercapnia, that is increased carbon dioxide concentration, you can proceed with non-invasive ventilation or else invasive ventilation. And if there is normal pH with hypercapnia, you can continue the treatment with oxygen with FiO2 of 24 to 28% via venturi face mask. And if there is normal pH and normal or low PCO2 with plus hypoxemia, you should titrate oxygen to achieve a target of 94 to 98%. So these are some case scenarios that you might be questioned in your MCQs. And yes, what are the investigations you should do in a patient presents with acute exacerbation of COPD? According to the NICE recommendations, you may proceed with arterial blood gases, chest X-ray, ECG, full blood count, urea and electrolytes as well. If the patient is on oral theophylline, you may check the theophylline level on admission. And sputum microscopy and culture if the sputum is purulent. And finally, if the patient is having continuous fever, blood culture is a must. Okay, in summary, if a patient presents with acute exacerbation of COPD, you may start with inhaled or nebulous bronchodilators, antibiotics if the sputum is purulent and if there are features of pneumonia only, prednisolone 30 mg daily for 5 days, controlled oxygen therapy to maintain saturation 88 to 92%, IV aminophylline, and non-invasive or invasive ventilation. So this is all about acute exacerbation of COPD. Now we'll get on to our MCQ. Okay, I think you have already answered this MCQ and let's see whether it's correct or not. The answer is non-invasive ventilation. Why? Because intravenous hydrocortisone, we may not know whether it's going to be successful or not because the patient was already started on prednisolone 3 days ago by his GP. And increased oxygen to 35% is of no need in this case scenario. As you can see, there is like respiratory acidosis in this patient. Decreases oxygen to 24%, of course that's not going to work. And intravenous magnesium sulfate. So according to this case scenario, the medical treatment has failed. So the next step in management is to start the patient with non-invasive ventilation, that's your BiPAP. Let's see some indications for non-invasive ventilation. COPD with respiratory acidosis, as like in this case scenario. Type 2 respiratory failure, which is secondary to chest wall deformity, neuromuscular disease, obstructive sleep apnea, and cardiogenic pulmonary edema unresponsive to CPAP, and waning from tracheal intubation. These are some indications for non-invasive ventilation for your patient. That's all about acute exacerbation of COPD. It's a very short summary. I hope you like this video. If you like it, please hit that like button and share with your friends, and don't forget to subscribe my YouTube channel for more short revision guides like this. We'll meet from another video like this. Bye bye.